last time I stood on this stage was for my senior band concert in 2005. I think I sat right over here with my flute in hand. Then I knew a couple things. I was going to Rice University in the fall, and I had always loved math and science, particularly physics and biology. And so I was going to give bioengineering a try as my major, because if I'm being honest, my mom thought it was a good idea. But freshman year, I got bogged down in all of the classes that I had to take for my major, and I started to question if bioengineering was really for me. That question was answered in an unexpected way by a professor named Dr. Rebecca Richards-Cordham, who came to my intro to bioengineering class to talk about a program that she was developing called Global Health Technologies. Essentially, the idea of the program was to combine biomedical engineering and global health by developing low-cost medical devices to be used in the developing world. The memory of that day remains so vivid to me because for the first time, I understood how and why bioengineering could be useful. So I signed up for her class. After taking a few classes with Rebecca, I had the opportunity to travel to the country of Lesotho for an 8-week internship, a country that I had never heard of before. You can see Lesotho here on the map. It's a tiny country located completely inside the country of South Africa. And it's extremely mountainous and very beautiful, and home to the Sesotho tribe. But it is also very resource poor and ravaged by disease. Close to 25% of its population are HIV positive. And I'll tell you why that is. It's a perfect storm. The main source of income for people in Lesotho is agriculture and raising animals. And so essentially they live off the land. But winters are harsh and the land can be arid. And so during the winter, many men go work in the mines in South Africa to make extra money to send home to their families. But while they're there, many of them contract HIV/AIDS and then return home and can spread that disease to their wives and partners. And what's really tragic is that many women don't know that they can pass on HIV to their child, either during pregnancy, delivery, or even after birth through breastfeeding. Consequently, a huge number of people in the country of Lesotho, including children, are HIV positive. While I was in Lesotho, I had the opportunity to travel around the country and learn about their healthcare system. And I wanted to show you this slide to illustrate the differences between our hospitals and theirs. On the left, you can see the Texas Medical Center in Houston, Texas, right across the street from Rice. It is one of the largest and most well-renowned medical centers in the entire world. On the right-hand side, you can see Queen Elizabeth II Hospital in Maseru, which is the capital city in Lesotho. You can see here a pile of broken beds that I photographed outside of the main entrance to the hospital. And what I want to stress is this is actually one of the most advanced and comprehensive facilities in the entire country of Lesotho. You go outside of the capital city and they are not able to treat diseases like they are here. And so what this represents is that there are huge disparities in healthcare around the world. The goal of the 8-week internship was to learn about healthcare in the developing world and to implement health technologies of our own design. The project that I took with me to Lesotho was called Lab in a Backpack. Essentially, you can see here the huge backpack that contains medical equipment that physicians can take with them to provide medical care in rural communities. The design includes a central power unit that can provide power to the different medical devices inside the backpack, and it can be recharged with solar energy. And this is what I had worked on specifically. During my time in Lesotho, I delivered the Lab in a Backpack to this remote clinic you can see here. And the only way to get to this clinic was to take a little 4-seater plane and land on a gravel landing strip on the top of a mountain. It's an experience I will never forget. The reason that this clinic was built there was because you could see these little villages on the surrounding mountainsides, and so this was a centralized location. The physicians would hike into those remote villages to provide medical care to the people there. Unlike any experience I have ever had, my time in Lesotho impacted the future trajectory of my career and my life. I wondered, how could such health disparity exist in this world? And so I decided to dedicate my life's work to improving healthcare in low-resource settings. But I had no idea how to do that. So I sat down with Rebecca, the professor I mentioned, and she told me something that I would never forget. She said that in order to solve challenges in global health, I needed to become an expert in something. Essentially, I needed to bring some sort of expertise to the table. And so she told me to stay on the path of biomedical engineering. And she said, this is like a highway with very few on-ramps, but lots of exits. To stay on this highway, I would encourage you to further pursue biomedical engineering in graduate school. And then when you see the exit you want, take it. So I decided to pursue a Ph.D. in biomedical engineering in Dr. Nimi Ramanujam's tissue optical spectroscopy lab at Duke University. What drew me to Nimi's lab is that she was developing low-cost optical technologies to address problems in women's health, particularly breast and cervical cancer. During my PhD, I had the opportunity to learn more about breast cancer and innovative light-based solutions for rapidly diagnosing cancer, particularly during surgery. So why focus on breast cancer? Breast cancer remains one of the leading cancer killers for women in the United States. In 2014, over 200,000 cases were diagnosed. 80% of those women are eligible for a procedure called a lumpectomy, where a surgeon removes the cancerous mass and a surrounding margin of normal tissue. A certain number of those women actually go on to receive that surgery, and then anywhere from 20 to 70% of those women, depending on where you get your surgery done, have to come back for a second surgery. So the question is, why do so many women need to come back for a second surgery? To answer that question, I want to show you a cartoon drawing of a lumpectomy. I drew this myself. Cancer is located in the center of this mass, and then there's normal tissue around the edge. And the very edge of the tissue is called the margin. So in this example, the margin is negative. There is no cancer touching the edge, and therefore no cancer left in the patient. This is in contrast to a positive margin where you can see there's a small pocket of disease on the edge of the tissue, and therefore still cancer in the patient. So the goal of our breast cancer research program is to develop technologies that could rapidly assess this margin during surgery. However, this is not a trivial problem. You have to survey a very large area of tissue, but also be able to pick up these small pockets of disease. Essentially, it's like finding a needle in a haystack, and you only have a few minutes to do it. Currently, there are very few techniques that surgeons can use during surgery to help them assess margins. Most of them actually just use their naked eye. And so the question is, how can we improve? To address this problem, our lab has developed an imaging platform based on a technology called diffuse reflectance spectroscopy. Essentially what we do is we take the specimen, which you see on our platform here, shine visible light of different wavelengths into the tissue, and collect the signal back. Based on the signal that we get back, we're able to create a heat map, which you see there. And then we can further interrogate areas that look suspicious for cancer, which are indicated in red. Through a technique called fluorescence microscopy, which I developed during my PhD. We're continuing to improve this technology and are using it in a clinical study at Duke. After completing my PhD this past summer, I had the opportunity to work on a new project focused in cervical cancer. And what's really interesting about cervical cancer is that through population-wide screening, we have been able to decrease cervical cancer rates in the United States substantially. This graph illustrates that point. Essentially, you can see here the estimated global deaths from breast and cervical cancer for 3 different years, and you can see that it's divided by more and less developed countries. So you can see in the case of breast cancer that many people are continuing to die from it, and the death rates are continuing to rise everywhere. So we still have lots of work to do. But cervical cancer looks different. Basically, you can see that the deaths in more developed countries are very small due to that widespread screening. But in less developed countries, cervical cancer deaths are growing exponentially. So what this graph tells me is that we have developed solutions for cervical cancer that we could potentially adopt and implement in less developed countries. Briefly, I wanted to show you the global burden of cervical cancer. Here you see the incidence rates worldwide, where the redder the color means the higher the incident rate. And you can see that the highest incidence and the greatest burden is in what we refer to as the global south: South America, Africa, and South Asia. Said another way, 500,000 women are affected each year, 270,000 die. And this translates to 1 woman dies every 2 minutes from cervical cancer. So by the time I'm done with this talk, 7 women will have died from cervical cancer. So what is done in the US to prevent cervical cancer, and why have we been so successful? And the answer to that is that we have this mass screening program. First, women are screened every few years with an exam called a pap smear, where essentially a physician will scrape off the cells on the surface of the cervix and then wipe those cells onto a glass slide, which will then be sent to pathology, and a pathologist will stain the slide and look at it under a microscope. If any abnormal cells are present, then the woman is asked to come back for an exam called colposcopy, where a physician applies acetic acid to the cervix, which is essentially household vinegar, and views the cervix under high magnification with a device called a colposcope, which costs $20,000. If an area looks suspicious during colposcopy, then the physician will biopsy the suspicious area and send the tissue to pathology, where a pathologist will diagnose. If precancer is present in that slide, then the woman is asked to come back for a procedure. If her precancer is grade 1 or 2, she can go through a procedure called cryotherapy, where essentially they freeze off the lesion. If it's grade 3, then she needs to go through a procedure called LEAP, where essentially they use a thin, low-voltage electrified wire to cut out the abnormal tissue. Both of these procedures only take 10 minutes, and then you're done. The cervix actually grows back, and you won't go on to develop cervical cancer. So in the United States, we can support this multi-tiered strategy because we have medical infrastructure, expertise, and patients actually come back for these follow-up visits. But that's not the case in the developing world. Studies have shown that over 80% of women are lost to follow-up care, particularly in rural areas, meaning they're not coming back for the treatment that they need. So if the strategy we have implemented so far in the United States is not going to work in developing countries, then how do we approach the problem? One approach that our lab is interested in using is to bring state-of-the-art diagnostic tools to the community level. Here you see on the left-hand side a commercial colposcope. It costs $20,000 and weighs over 150 pounds. You can imagine that this is not something that's affordable in the developing world. On the right, you can see a colposcope called the pocket colposcope that our lab has developed. We can build it for $250 with off-the-shelf components, and hopefully if it's manufactured, it could even be cheaper than that. And it only weighs 1 to 2 pounds. You can also connect it directly to a smartphone so that you can capture, view, and send images to a physician. Right now, we are using this in a clinical study, and we've shown so far, by sending it to 8 colposcopists around the world, that we can achieve image concordance on the level of 80% between these two devices. And so we're moving forward with a clinical study right now and working with commercial partners out in California to help us get this technology into the hands of community healthcare workers in rural communities who are on the front lines so that they can implement this technology and screen women. What's really exciting for me now is that my advisor, Nimi, has started the Center for Global Women's Health Technologies, the goal of which is to create sustainable solutions for women's health. And so what I'm actually able to do, finally, is integrate biomedical engineering with global health, something that I'm incredibly passionate about, and I believe it's an amazing area to work in. So I want to conclude by leaving you with a question. And the question is, what does it mean to cure cancer? I used to think that it meant a fancy vaccine or a drug that could cure and kill cancer cells and leave all of the normal cells alone. And while that might be the case for some cancers, cervical cancer got me thinking about the problem differently. Essentially, if we can catch cervical cancer early enough when it's still at the precancerous stage, and then get a woman treated in 10 minutes, she will not go on to develop cancer. Said another way, I believe that no woman should die from cervical cancer in the 21st century. And so many brilliant people have dedicated their lives and their time to solving this problem. I encourage you to be one of them. And I hope that the next time I stand on this stage, we have taken great strides to reduce and ultimately eliminate cervical cancer. Thank you.